Hello, everyone. I'm John Lynn, the founder and chief editor at Healthcare IT Today. We're excited to bring you another in our series of interviews with top leaders in healthcare IT. Today's guest is Yousuf Ahmad. He's president and CEO of AssureCare. Welcome, Yousuf.
Thank you, John, for having me. It's my honor and privilege to be here today.
Yeah, well, I'm excited to learn more about AssureCare and the work you're doing. So for those that don't know you, tell us a little bit about yourself and AssureCare.
Well, I am what people call a one-trick pony. For the last 25 years, I have done nothing except healthcare and what's called the tripod of American healthcare, which means large insurance company, large physician group practice, and a large multi-hospital system. So I've been really a student of healthcare. I've also studied public health at a doctorate level. So I'm a true nerd when it comes to healthcare, and that's all I know, and that's all I have done. Came to AssureCare about 6 years ago, and it was more of a calling for me. If I could help, I could help 3 million people in greater Cincinnati doing what I did, running a health system, or I could impact 7 billion people across the globe doing what I do at AssureCare potentially. So we build technology that at its very core helps a human life get connected to its overall healthcare ecosystem.
Okay.
And I'll talk more about it throughout the conversation, but I've been here almost 6 years and feels like I was here yesterday. So we have amazing group of associates, my colleagues, an exceptional group of customers, and a very supportive board. So I kind of got lucky.
Yeah. 6 years in healthcare time is like 1 year everywhere else. Is that?
Yeah. 6 years in tech. Yeah, exactly. Yeah. So I've done healthcare for 25 years and 6 of them include this AssureCare work, considered healthcare technology.
Yeah. Well, there's something about healthcare. It gets in your blood and you just can't let it go. It's, I know that feeling. I came from a different background. I'm a tech guy, and then I got in healthcare and, there's no leaving now. So
yeah, it's funny. I was the only graduate when I graduated with a degree in computer information systems. I was the only one who at the time picked a podunk industry called healthcare, and everybody else went to more attractive industries like aviation and banking and technology. But 25 years later, when we all regroup as a reunion, I feel so blessed because it's the largest industry in the country. It's the only industry where a person comes in their most vulnerable form, and they come looking for hope. They come looking for care. And it's extremely rewarding to my soul. Whether I was doing healthcare delivery or now, it's really, I don't know what else to do, but I'm married to it for life.
Yeah, that says a lot about you. So that's awesome. So, with all this background in healthcare, what are some of the healthcare market challenges that you're seeing now? And what is AssureCare's approach to kind of solving these challenges?
A great question, John. We look at macro trends first. So healthcare is, these statistics, they're kind of boring now. People have become immune to them. We spend, between $3 and $4 trillion. It's about 19% of our GDP. So what? So I take it from a different slice.
Okay.
The macro trends are, for example, did you know that every day 18,000 Americans turn 65? And that trend will continue for the next 18 years.
Wow.
So there is a longevity, which is a good problem that's happening in America, a longevity of life, but that also comes with chronicity of disease. Mm-hmm. So that same statistic of person turning 65, your average Medicare consumer is on 8 active medications prescribed by 6 different providers who don't talk to one another. Yep. So that's a macro trend. It's a defined problem that we like to provide solution for, to say, hey, let us help you care coordinate that, because our technology helps with whether it's a pharmacist, a nurse, a physician, or a social worker, help your care be coordinated through the platform. So we look at macro trends. That's one of the challenges. Cost is very high. Yeah. I don't know about you, but I've been a healthcare both student and a leader, and my healthcare costs for my employees and their dependents keep going up. So I think instead of being payers of healthcare, we need to start acting like buyers of healthcare and demand a reduction in cost, an improvement in access to care, and an improvement in engagement of care. Those are.
So give me an example of that. I mean, you're right about coordinating the care. And, I through my work with my church, meet with a lot of older people, and it's amazing how much their lives revolve around healthcare. It's like their social network is their doctors that they visit each week. It's kind of crazy, right? But, give us an idea. What can AssureCare do to kind of help solve some of this care coordination problem?
Sure. So I'll preface it by saying my response that most of healthcare solution today is provider centric. Your average doctor's visit is 15 minutes long, irrespective of the severity of the patient. It's how he or she gets reimbursed, which is shocking. And our technology, why we are different, is because we are member centric. We actually follow the human being. That is why we get to inculcate what's called social determinants of health. These are factors that have a higher impact on health outcomes, more than what your genetic code lends to you to do or what physicians and hospitals do to you. So where you live, your zip code is a better predictor of will you survive a heart attack? Are you in a safe relationship, or are you in an abusive relationship? Most people don't know that for seniors, the biggest cost item is isolation.
Yeah.
When was the last time you heard a doctor talk about Mrs. Smith being isolated at home and what to do about it? People say, go work out in your neighborhood. Well, is the neighborhood safe?
Yeah.
Is English your first language? Are you able to understand what is being communicated to you? Race, ethnicity, language. I'll give you one example. I am not proud of this fact, but in Cincinnati, Ohio, everything else adjusted for. By that, I mean education, household income, etc. A Black male diabetic in Cincinnati, Ohio, a Black male diabetic is 6 times less likely to receive the proper diabetic care compared to his Caucasian counterpart. The sad part is the same statistic applies in every other metropolis of America. And we have had electronic medical records for 25 years. It's because they were built with the provider in mind. What we are building is with the consumer in mind, with the patient in mind, with the care receiver in mind. So we follow the member. And that's a key distinction in what we bring as a solution to the industry.
Yeah. So, I mean, in this space, there's a lot of, I would kind of describe as population health vendors, right? Understanding the population, the social determinants of health, et cetera. There's a lot of vendors in that space that you're really working in. What makes you different from maybe some of the other vendors in this space that are really attacking similar problems?
I think the first thing is about being member centric. And I agree, there are a lot of players. We are also considered a population health solutions provider. I would also say we're a population health market maker, because you can't just go value-based care 100%. I think the fact that we come from the industry brings a lot of credibility. I ran a large multi-billion-dollar health system before I came to AssureCare. That means, for example, I'll give you one small stat that might be helpful to you as a consumer of healthcare. I know you're also a great researcher, John, from what I've been edified by my team. So a lot of companies will ask, if I'm a payer and my patient, my subscriber gets admitted to a hospital, share that information when they're being discharged. Where we are different is we will say, hey, we want to get that information upon admission. So that if you get the information upon admission, you can help influence length of stay. You don't want an unnecessary length of stay. Extra day costs you between $15,000 and $25,000. And we know, running hospitals, that an unnecessary stay, you're also prone to what's called an iatrogenic error. You don't want to be in a hospital unnecessarily.
Yep.
Absolutely. So that's kind of a distinction of how we come about. The industry knowledge, technology is member-centric, inculcating social determinants of health, being real-time. We like to be as real-time and not batch process. So having a real-time interface with the hospital, a real-time interface with a health information exchange, is something we do. Connecting remote patient monitoring devices. Today's iWatch can tell you the EKG, can tell you blood pressure, can tell you your heart rate. It's all FDA approved. So let's leverage that within an everyday life of a consumer without being a fear monger.
Yeah. Well, we're just getting started down that route. Although, I've been watching the evolution over a decade. But yeah, it's happening finally. It's here. So, it was interesting. You're right. I like to research this area. I love this. And when I was looking at AssureCare, I found it fascinating that you work across payers, providers, and then also pharmacies. And the odd one out there for me, right, is the pharmacy. Like, tell me about your work with pharmacists and how do you see that role in all the work you're doing?
Absolutely. I mean, I am so humbled and honestly thrilled with the work we're doing in the pharmacy area. So think about this. I call the pharmacist in America the most underutilized clinician. Often they have a PharmD degree, which is a 6-year degree. But until a few years ago, they could barely be allowed to give a flu shot. Yet an 8th grade educated medical assistant could give you all kinds of injections and vaccinations. Now that is changing. COVID, the pandemic, has provided a positive impetus into allowing the pharmacists to do a lot more, practicing at the top of their license. So that's from a scope perspective, but from a cost perspective, after your hospital cost, the second highest cost item are drugs, are your medications. 9 out of 10 Americans live within 5 miles of a community pharmacy. And a pharmacist is a very trusted resource.
Yeah.
We frequently see our pharmacist more than we see any other care provider. So I always thought before I came to AssureCare, why is this such an underexplored, undertapped, untapped area? Because a pharmacist is a very qualified specialist, if you ask me. Mm-hmm. So when I came to AssureCare, my very first week, I said, we've got to provide a solution to the pharmacy world. And we created a platform called Medication Therapy Management, also known as RxCare. Because of the statistics I mentioned, I gave you that Medicare example, right? 66% of adults today are taking 5 or more drugs. Think about it. 66% of the population and 27% of the population is taking 10 or more drugs provided by different prescribers and providers. So a pharmacist kind of becomes the default quarterback.
Sure.
And I feel like you'll see a lot more allowance, acceptability, admission, and encouragement by payers, the government, to say we'll allow the pharmacists to do a lot more. And then in many parts of America, there's tremendous maldistribution between physicians and population density. Yeah. So they also help address that aspect. And you're seeing today that more and more payers are now reimbursing pharmacists. Because if a pharmacist can help me coordinate my drug regimen and it keeps me away from a sentinel event ending up in an ER, then it's really better for everybody. It's first of all better for the patient, but it's better for the payer from a cost perspective. It's better for the employer. I get back to work sooner. A lot of multiple beneficiaries. So pharmacy is an area where, we feel like we took the lead when a lot of people told us, hey, stick in the payer side, and that's the more, but again, from a macro trend interpretation perspective, this was an area to be. And there's more coming. There's pharmacogenetics coming.
Yeah, for sure.
I mean, you're a handsome Caucasian man, John. I'm a Mediterranean dude. We would process the same drug differently purely because of our DNA. Yep. There's also nutrigenomics coming. We process the same food item completely differently because of our genetics. That's an area we'd like to explore in the future here also.
No, I can't wait for pharmacogenomics to mature, right? It's showing some good promise. I think your comments, though, about the pharmacists are fascinating. I think of just a couple examples that, I'm spoiled working in healthcare. I'm sure you know this as well, that, I worked in a healthcare organization where there was a pharmacy and I was supporting the pharmacy. And so there were a couple times where I went to the pharmacist to understand what had been prescribed for my son and for my ex-wife, right? Like I went to them and asked him, right? And so it was interesting, to your point, that there's a trust relationship there with a pharmacist. And luckily he could take the time because he was my friend and I worked with him, right? But he took the time and he improved my compliance and my family's compliance with what was prescribed, because I had some fears that weren't addressed in that 15-minute quick office visit that I didn't even know what to ask because they just prescribed it, right? But now I'm with the calm of the pharmacist. I'm like, so what are the risks for my child of taking this drug? So I think there's a real opportunity there, as you kind of described.
Absolutely. And especially in the retail setting,
Yeah.
there's a lot of chaos. You have the pharmacy tech, you have the pharmacist, you have some other junior person, and we want to make sure that our platform allows the pharmacist to be more patient facing, and any things like prior authorization on the phone with the payer, the pharmacy tech can handle it. The other area that that drives me, motivates me, John, is I am blessed to live in a place in greater Cincinnati where from a mango to a hard drive comes to my home in 30 minutes from ordering.
Wow.
Yet a first-time cancer patient gets their drug within 21 days from the time it's ordered. That is unconscionable. That should be unacceptable. And they have to go through all kinds of hoops, getting it approved from the specialty pharmacy or the payer. So I think the next generation will be a lot less tolerable, and they're a lot more intelligible in saying, hey, we expect a bit more service and give me an ETA. My oncologist ordered the drug. Has it been dispensed? Is it on a truck somewhere? Has it reached the infusion destination? When do I get it? So that's another area where we are trying to help our customers who are retail pharmacies, specialty pharmacies, to be a bit more of service because we can afford them the technology to do so.
It's funny you say that. Literally on my desk right here, I have something I may do for my knee that has to be ordered from a specialty pharmacy, and they're like, "Yeah, expect 2 weeks at least." I'm like, "All right,
Yeah.
that's great news." But yeah, let's shift gears a little. I mean, you talked a little bit about the issue of patients really not being the center of the care continuum in much of healthcare. What are you doing to kind of change that and to make the healthcare system less just disjointed?
I think bringing data from disparate sources and creating what we call a universal health record is something we're working on.
Is that possible? A universal health record? I mean, that I've been pushing for that for a long time, but it's like,
and I think tough. It's people like you and your ilk who are going to make that happen, because most of healthcare recipients have been at the behest of what is offered. They haven't been as demanding. I mean, think about, have you ever seen a hospital bill? It's complicated. I have a doctorate, 3 masters, 2 fellowships, and I ran a health system and I cannot figure it out. So point of that is we make healthcare complicated, I think intentionally.
Yeah.
We've got to be as intentional in making it simplified, right? There are other things that have to be brought in that universal health record. For example, nutrition. Food as medicine is a concept that is proven. And then there are certain chronic diseases that are contained because of food. I'll give you one example just to make a finer point. You take multiple sclerosis. It's an autoimmune disease. It's a Caucasian disease for the most part. People are vitamin D deficient. It's discovered initially through a MRI. You see spotting on the brain. Mm-hmm. It's confirmed through a spinal tap. And the treatment is $50,000, $60,000 a treatment per drug, whether it's Tisabri or Ocrevus, once a month or every 6 months treatment. But the only other way to contain MS is through a gluten-free diet. Yet the nutrition world and the proper healthcare delivery world are so disjointed. We like to bring it together. And you can also have excessive nutrient overload, what I call. That's also kind of been proven. And you can also be deficient. So vitamin A deficiency in children can lead to blindness. But vitamin A deficiency in adulthood is not as harmful. So, but I feel like in my observation of 25 years, the healthcare delivery side have treated the nutrition side as a one-off, just like behavioral health has been treated as a one-off. These have to be embedded in the everyday delivery of care. And that's why I feel like creating a universal health record has to show price transparency, has to show other consumption that I take, not just my medication. It has to show what food am I ingesting,
Mm-hmm.
Do you know your macronutrients? That what people know: carbs, proteins, fats. Okay. Do you know your micronutrients? What vitamins and minerals are essential?
Yeah.
So I think part of that will be educating in a soft hand-holding manner the ultimate consumer. But I think people like you and others have to demand that, have to expect that, hey guys, I'm sick and tired of always being the last person to know about my own health versus being proactively informed and having a longitudinal view of your own record that you
Mm-hmm.
control, not your clinical team.
Yeah. Not to be too much of a cynic, but the challenge with the nutrition is there's no money to be made off of a gluten-free diet, right? I mean, like I think that's some of the challenge, right? Is that the nutrition doesn't, and that's maybe why we need to push towards the value-based care in a bigger way. No.
I totally agree, and I think you will see some of these retail giants. I will not name them by brand,
Sure.
but I believe you will see them starting next year in partaking in value-based relationships, because in some parts like California, groceries are a covered benefit.
Yeah.
Air conditioners are covered benefits. Humidifiers for asthmatics are covered benefits. But I think because we in healthcare have, I don't know if it's intentional or not, chosen to neglect the nutritional world, that blending is going to happen soon.
Yeah.
because of the MS example I gave you, and then there are so many other examples where you could be excessive nutrient or nutrient deficient, and it can cause problems, chronic disease problems.
Yeah. So what's next for AssureCare?
So for us, we like to kind of continue on the ease of use of healthcare, and that's one aspect where, like I said, if a Mango to a hard drive can come to my home in 30 minutes, why should my back surgery take 2 weeks to be approved? So we're working on technology that in the exam room, you mentioned your knee, John, I'll just pick up on that. If you needed something, a scan approved for your knee, and you're in your orthopedic or knee specialist exam room, and they need an MRI, your payer should approve it right then and there. It should go through an evidence-based check, should go through a payer policy check, boom. It should approve it or disapprove it with a reason. But you shouldn't have to wait 2 weeks to get a snail mail letter. So that's one track.
They can fax it. Oh, wait.
And you'd be shocked how much fax still happens in America.
We shouldn't have to do either.
Yeah. So that's one track. The other track is this whole pharmacy track I talked to you about, from retail pharmacy, specialty pharmacy, nutrition, bridging all that is second. Third is coming up with this universal health record, nice. Where I'm sure we'll get a lot of pushbacks from some of the establishment, but we feel like the intelligent buyer, not payer of care, the intelligent buyer of care will warrant it, will accept it, will promote it, will ask for it. We're also looking at artificial intelligence and machine learning. We know that it's proven that when a robot reads a mammogram, it has a lot more accuracy than a human radiologist. Nothing against my compatriot radiologist, but let's just use technology where it's proven.
Yep.
Why do we have to fight it? I'm shocked that despite all the technology we have in healthcare, the third leading cause of death in America is still medical errors. And I think it's not so much to blame technology, but I think it's because we haven't engaged the member as much. If you engage the consumer, we still end up amputating the wrong limb in America. Well, how is that even possible? Right? So I think we have to be less accepting of that. But we should be asking for more member-centric technology. But anytime you engage a consumer, health outcomes have been proven to be 30% or more better. Simple things like, well, Mrs. Smith, this is how you take a medication. You can score it, you can split it, take it with food. It's going to cause nausea or sleepiness. Don't drive. I think that humanizing care has to take place a little bit more. We want our technology to enable the humanization of care. Making it more personal. Can I see a record where I have my entire purchase of healthcare, including my nutrition? If I have a health savings account, it should tell me, what's covered in my network. Can our technology help navigate healthcare easier? That's also in the works for us. So
That's
there's a lot of
great.
exciting stuff. Yeah.
Yeah, I love the vision. I mean, I think many times technology can get in the way, but implemented properly, it can humanize the experience and can allow humans to do what they do best. So I love the vision, Yousuf, and you gave us a lot to think about. So I appreciate you taking the time to share your perspectives and insights. And thanks everyone for watching. If you want to find more great healthcare IT content like this, be sure to check it out at healthcareittoday.com. Thanks, Yousuf.
Thank you, John. My pleasure.